pediatric and adult, and very exciting work. I'd like to briefly open up the floor for questions. Please state your name and affiliation before asking the questions. So I'll open it up.
Hi, John Geaver with MedPage Today. Question for Dr. Roth. I'm sorry if I'm killing your name. Are there other conditions for which this drug might be used? There's certainly many diseases that involve the complement pathway.
That's a good question, actually. So tonight actually will be a presentation on the use of sutimlimab in ITP.
Mm-hmm. Okay, and what's the regulatory status of this drug for either of these conditions?
Oh, I cannot comment on that.
Hi, Neil Osterwald with Hematology News, also for Dr. Roth. So do you envision that this would be a maintenance therapy, continuous maintenance therapy for these patients? And I noticed that, so your mean age of the patients was 55. Is this an acquired disease, or are there
71.
congenital cases?
71.
Sorry?
The mean age was 71.
71, oh, I'm sorry, okay. But the range, I guess, was 55.
Yeah.
Right,
Yeah.
you're right, okay.
You're right.
So it's an acquired disease?
It's acquired disease. It's an autoimmune disease which builds IgM, and it has an underlying lymphoproliferative disease.
Okay, and one quick question for Dr. Brodsky. Do you see patients with this condition?
I do.
And how do you feel about what you just heard?
I think it's very exciting. These patients are very difficult to treat, and there's really been no FDA-approved drug. Right now, we usually use Rituxan first line, but only half of those patients respond, and usually it only lasts for about 6 months or so. So this is a welcome addition.
Okay, thank you.
Alex Gasolino, Medscape. This is a question for Dr. Wei. The last trial, which was HOVON 97, which used injectable azacitidine, showed relapse-free survival but no OS benefits. And when you compare HOVON 97 with your study, the patients received cytidine approximately for the same period of time, 12 months, because your median cycles was 12. So I'm wondering whether you could comment on why the QUASAR study shows an overall benefit compared to the other one. The other question I have for you is, how many patients in your trial are still on maintenance AZA, and how long have they been on maintenance AZA?
Certainly. So with respect to the HOVON 97 trial, this was a smaller study, and so in fact at 12 months only 1/3 of patients were still on therapy, so the median number of cycles was likely to be substantially less than 12 cycles. Whereas in this trial, patients had a median of 12 cycles of therapy. Furthermore, with the HOVON study, patients had to cease therapy after completing 12 cycles of therapy, and this is probably partly logistical, but also patients need to come in to the hospital to have an injection or to receive it by a home nurse 7 days per month. So over a year, that's 84 visits to the hospital. With CC486, being an orally administered therapy, obviously it's far more convenient. In the HOVON study, patients only received azacitidine for 5 days per cycle, whereas here 14 days per cycle was administered, so it's a longer duration of exposure. And as I showed, patients received up to 80 cycles of therapy with CC486, and currently there are still over 40 patients still on therapy. And this trial actually was commenced in 2013. So in terms of why this therapy works compared to azacitidine injectable, we don't know exactly the mechanism, because the pharmacodynamic profile is actually quite different between the two therapies.
And how long has been the longest patient on oral cycles?
80 cycles. 80 cycles. 7 years.
Matt Brindle from BioWorld. This is a question for Dr. Williams. There are other repressors of fetal hemoglobin. Do you worry that one of those could take over if you silence this one, the BCL11A?
Well, the purpose of our trials is to, in part, look at the longevity of the gene modification. We have no indication at this point that that's occurring in our longest treated patient, 18 months. Just to give you a sense for that, that young man had a stroke at age 4 and had been on monthly blood cell transfusions for 20 years, and for the last 18 months has not required any blood transfusion. So this is very much a dramatic phenotype change from the persistence of the knockdown of B-cell11A. I think we still don't know, of course, of all these approaches, which ones will be long-term most effective, and of course, in the end, which ones will be adopted in the sense of a drug approval, but that's part of what we're trying to study at this point.
Thanks. Hi, Neil Osterwell with Hematology News. Dr. Iacobucci, a question for you, please. Will your discoveries about the genomic profiles and transcriptome profiles of these diseases be able to inform treatment of patients with MDS, for instance, perhaps prevent AML in these patients?
Yeah, that's a good point, exactly where we aim at, because we need to know the genome then to guide treatment and to prevent progression or relapse. And so what we are doing, in addition to the genomic part, is also establishing a repository of patient-derived xenograft. And so in this way, we can have the genome information, we can have the biological material in vivo to test different therapies. So we can have the information to guide therapies, but then also a platform to test these therapies before going to patients, and so see exactly which combinations of mutations can be most or less sensitive to specific treatments. So definitely, yes.
Thank you.
Actually, I'd like to ask Dr. Brodsky if you wouldn't mind commenting on Dr. Williams' work. I think he did a good job explaining that there are a variety of different approaches that are being evaluated, and the results seem to validate this approach. And how would you characterize the clinical results that have been seen to date? If you feel comfortable commenting on that.
Yes, sure, absolutely. So these are very exciting results, obviously. I mean, there are many approaches, as Dr. Williams mentioned, to cure sickle cell disease. And which one is going to be the best? I mean, I imagine probably several of them are going to fit in the paradigm. We're going to have to look at late effects. We're going to look at long-term efficacy. Cost. I mean, these are all going to factor in. The exciting thing is that there are now multiple ways of going at this previously incurable disease, and we're seeing a lot of cures for sickle cell disease now, and this is likely going to be one of them.
Lynn Peterson with Trends in Medicine. So as a follow-on to the last question, and anyone on the panel, really. But cost, can we really think that gene therapy is viable for sickle cell, given the cost of gene therapies that are existing now?
I'll be happy to try to answer that question. I think you have to look at the cost of taking care of the complications of sickle cell disease over the lifetime of an individual, which is a significant amount of cost for a large fraction of the patients. And I'll just give you a concrete example. At our institutions and most institutions, if you have an allo transplant for treatment of sickle cell disease, which is currently covered by both most third-party payers and by Medicaid and Medicare, if that transplant goes completely without complication, the cost is probably $500,000. But if there's a single complication, the cost can easily go above $1 million to $2 million per patient. So I think, of course, no one knows what the cost of these genetic therapies in the end will end up at from the standpoint of sickle cell disease. But it's likely they're going to be in the range that makes them competitive, if you will, with allotransplantation. And I think from the standpoint of the prevention of the long-term complications, which are really dreaded in the disease, and the morbidity associated with those and the cost, these will be therapies that are not only transformative for the patient, but they will be ultimately transformative for society in the sense of the cost, overall cost of taking care of these patients.
What, Lynn Peterson with Trends in Medicine again, what % of sickle cell patients are in this kind of a severe situation where you would even consider this, where they become that expensive a patient?
Sickle cell, one of the things that I didn't have time to talk about, but I'm sure you're aware of, is one of the issues with sickle cell currently is that while everyone has the same mutation, the disease severity between patients is markedly different. And in fact, the disease severity can change in the same patient with time. So it's hard to answer your question, but I would suggest that there's a fraction of patients, probably 10 to 20%, who have the most severe and repetitive admissions to the hospital, but probably on the order of 50 to 60% of patients have intermittent complications. And we know from long-term survival studies that even if you don't have apparent acute complications, your lifespan is significantly shortened. So I think in that sense, almost all patients will have an opportunity to benefit from this approach. Now, I would add that other types of transplants, such as haploidentical transplants and allotransplants in general, are also getting better and better with respect to not the efficacy, they're very efficacious, but with respect to the lack of complications. And so I'm not suggesting that the only approach, curative approach in the future is going to be gene therapy. But certainly when you talk to families, you almost always get a response that they prefer to use their own cells as opposed to someone else's cells to attempt to treat their disease. So this is going to be, as Dr. Brodsky mentioned, what's really great about this is for me as a clinician, you know, for the first time in 30 years I've been taking care of sickle cell patients, there are multiple approaches that seem to be working early on, and I think that predicts that multiple approaches will be adopted in the future that cure the disease.
Alice Goodman with the ASCO Post. So I want to ask two different questions. Dr. Way, so 80 cycles. So these people are basically on lifelong therapy until they progress? Is that the idea? And do they ever get off maintenance therapy? That's my...
Yes, of course. We do have patients who have stopped therapy for various reasons. CC486 is quite a convenient medication to take, so it is possible for people to take long-term therapy. There are of course people that did cease therapy for various reasons, some because of toxicity, but if patients didn't have substantial toxicity, remained in remission, then there is certainly I think the intent that remaining on therapy is considered quite reasonable, because even though we are prolonging relapse-free and overall survival, at this stage, particularly in older patients with AML, we still don't consider this to be a curative approach. And so the treatment is aimed at trying to delay relapse, improve survival, and give patients a better quality of life for as long as possible.
Dr. Brodsky, would you please, would you go into a little more detail for why Dr. Brown's presentation and Dr. Way's presentation are important? Or would you prefer to talk to me afterwards?
So Dr. Brown's presentation, I mean, I think he made it pretty clear. I mean, this is a new standard of care. I mean, the big problem with pediatric ALL, and I'm an adult hematologist, but Dr. Brown has taught me quite a bit, is when they relapse, it's very hard to get them back into remission. And when they relapse, the only way we really have a chance to cure these patients is to get them to transplant. And what they clearly showed is that with blinatumomab, they have a much better chance of getting to transplant and being cured of their disease. I don't know if you want to add anything.
I agree.
So with the AML study, yes. So again, this is a very difficult problem, the older, poor risk AML patient, and there's really been nothing for these patients. You know, it's been pretty easy to get these patients into remission, but these remissions are very short-lived, and you know, there's never been any consolidation that's really been effective, and I think we're seeing for the first time there's an oral drug that can lead to not only disease-free survival, but overall survival benefits in these patients. So again, I think this is practice-changing.
The CC486 and azacitidine, not just that they're injectable or not injectable. Azacitidine's been around a long time, right? So what is, in plain words, what is so different about this drug?
Molecularly, they're identical, but I think the transformative aspect of CC486 is that it's an oral delivery schedule. And although this trial, which hopefully will lead to a label for CC486, was done in remission, this is just the first step. And I think having now an oral form of azacitidine gives us enormous potential for utilising this agent in many other AML settings. For instance, frontline elderly AML has been traditionally based upon azacitidine-based therapy, and elderly AML makes up 2/3 of the population of patients with this disease. A lot of these patients are currently getting azacitidine. Imagine a future where we can utilise an oral medication instead of azacitidine given 7 days a month for long term. Furthermore, azacitidine given orally could potentially become the building block for multiple more effective drug combinations which are already being explored in the clinic. For instance, azacitidine plus venetoclax is giving response rates of almost 70% in older AML. Azacitidine plus IDH inhibitors, similarly, azacitidine plus FLT3 inhibitors. So really, it's like the fundamental building block for new combinations which will hopefully have transformative potential for patients with this disease using an oral, no injectable form of schedule of delivery. And I think for patients, that's a major step forward. That is the potential. However, all of these possibilities needs to be formally validated in clinical trials, but now we actually have the tools to be able to conduct that type of research in the future.
Mary Caffrey, American Journal of Managed Care, for Dr. Brown. Can you elaborate a little bit on the burden on the patients, these young patients with the infections that appear that you now be able to avoid?
Sure. The burden of infections was primarily seen with the chemotherapy arm. I want to mention also, though, that the first month of therapy before randomization was also associated with high rates of infection. When we look at risk factors for which patients within the randomized treatment were most at risk of life-threatening or fatal infections, it was definitely skewed towards adolescents and young adults, and that's something that's been seen in prior studies of ALL as well. And so I think it's likely that these, the impact of the improvement of survival with immunotherapy in the relapse setting may be particularly important in that AYA population, since the burden of infection seems to be greatest in those patients with chemotherapy.
Adolescent and young adults.
Thank you.
Tom Collins, excuse me, with International Medical Information. Dr. Usmani, you mentioned in passing the 5 treatment-related deaths in the DARA arm. How concerning were those to the investigators, and what do you make of that thus far?
Thank you for asking that question. And I'll be elaborating on this in the late-breaking abstract in more detail. So there were 5, fatal treatment-related adverse events on the KD DARA arm compared to none on the KD arm. 4 of those events were related to infections. And we know from other randomized phase 3 relapse refractory as well as frontline studies that the incidences of infection tends to be higher in both daratumumab as well as carfilzomib based regimens. But we haven't seen the fatal AE signal. I think you have to keep in context the patient population. And also the fact that there were no differences in overall survival. The attribution was definitely associated with this because, as per the definition, patients, it would be a treatment emergent AE if even if the therapy has been discontinued and the event happens within 30 days after that. But it's certainly pointing more towards infections rather than any other worrisome signal.
Any other questions? So, all right, well, if there's no other questions, this concludes